Hello and welcome to part one of two presentations on the wrist. So we'll start with a quick review of the normal anatomy, focusing on the lateral projection, and then we'll look at soft tissue signs, mechanisms of injury, and then look at the four common types of wrist fracture, the Collies, Smiths, Bartons and reverse Bartons. Here's a quick slide of the lateral projection, just to remind you of the anatomy. You may wish to pause, otherwise just let the video run and we'll move on to the next.
There are a couple of soft tissue signs in the wrist for you to be aware of. Just quickly, we'll just do a quick refresher. Remember, air is visualised as being black on a radiograph. Soft tissue, which as we got example here and here, this is a light grey. Fat, which we can see with this stripe here, fat is a much darker grey, and then of course bones are much whiter. So on the left we have a cone down view of the scaphoid on the PA view, and this dark grey stripe that lies just lateral to the scaphoid, this is the scaphoid fat stripe. Now it's important to be aware of it so that you can recognise it. The only problem with the scaphoid fat stripe is that it's not terribly sensitive, because unfortunately a significant number of individuals you can't actually visualise it, so therefore it's not a very sensitive sign, but it's something to be aware of, and if you can't see it, then may indicate that there might possibly be an underlying bony abnormality. But remember, not all patients have one visible, so it's not that sensitive. Conversely, on the right, on our lateral view, we can see this dark fat stripe here, and this is the Pronator Quadratus fat stripe, and this is actually a lot more helpful. So normally it should lie a few millimetres anterior to the anterior cortex of the distal radius and ulnar, and it's visualised as it is here as a dark grey stripe. Now what happens is that if you have, for example, an underlying fracture to the distal radius, you can then get some bulging of the Pronator Quadratus fat stripe, or even complete obliteration, and that's because of the hemorrhage of blood out of the escaping out into the surrounding soft tissues with the fracture, causing this fat stripe to bulge or be obliterated. So this is a much more helpful indicator to raise the possibility of potential underlying abnormality. Now, as you're all aware, the most common mechanism of injury for injuries to the wrist is fush, a fall onto outstretched hand. Now, the great thing about the wrist is that actually the age of the patient can be quite a good predictor of the type of injury that patient's going to sustain. So what happens when you have a child that's between 4 to 10 years, you tend to get this transverse fracture of the distal radius, and which may or may not include the ulnar. Once you start to get to 11 to 16, when children are going through a period of growth spurts because they're reaching puberty, you get a slipped epiphysis. Now remember, the physis is the unossified cartilaginous zone, and so this unossified cartilaginous zone is very slippy, and this is why these kids, when they injure themselves, they get a slipped epiphysis, because they get a horizontal fracture through the physis, which causes the epiphysis to slip off the side. Okay, once you get to 17 to 48 years of age, then patients are more likely to sustain a scaphoid fracture. And once patients are over 40 years of age, they're more likely to sustain a Colles fracture. And this is particularly associated in postmenopausal women when they start to get osteopenic bones. So they very classically get these Colles type injuries. There are 4 very common types of distal radial fractures. The most common by quite considerable margin is the Collis fracture, and I'm sure you see at least one of these per day. So when we talk about a fracture, we always talk about the distal portion in relation to the proximal portion. And so with a Colles fracture, what happens is you get this transverse fracture causing a real gape to the volar or anterior cortex of the distal radius. And then you get this dorsal deformity with comminution of tiny little bone fragments, comminution, creating this dinner fork deformity because you have dorsal angulation of the distal fragment. And this dinner fork deformity is really quite classic, and I'm sure a lot of you have seen clinical indications with just literally writing dinner fork deformity, and so already they're thinking there's a Colles fracture, or almost certainly there is a Colles fracture because of this abnormal shape to the bones. Conversely, a Smith's fracture is volar or anterior displacement of the distal fragment. Now, these aren't as common as Colles, but they do occur. So it's important to be able to recognise the difference between a Colles fracture with dorsal angulation and distal fragment in comparison with a Smith's fracture, which is anterior or volar angulation of the distal fragment. Now, a reverse Barton's and a Barton's fracture, these are intra-articular fractures that involve the radiocarpal joint. So whilst your classical Colles and classical Smith's fracture do not involve the radiocarpal joint, the drudge, the distal radial ulnar joint, may be affected, and if that's so, then that is still considered to be an intra-articular fracture. It's just the fracture, the intra-articular component is involving the drudge as opposed to the radiocarpal joint. So I always remember a reverse Barton's fracture because reverse contains the letter V, and what a reverse Barton's fracture is, it's an intra-articular fracture of the radiocarpal joint with volar displacement of the distal fragment. But significantly, the whole point with a reverse Barton's fracture is that the carpals, so your lunate will migrate with the distal fragment. So that's really important. So a reverse Barton's is an intra-articular fracture of the radiocarpal joint with volar displacement of the distal fragment and with the carpus migrating with the fracture fragment. Conversely, a pure Barton's fracture is an intra-articular fracture of the radiocarpal joint with dorsal displacement of the fracture fragment, and the carpals, the lunate, is migrating with the fracture fragment. Now, there are a couple of other things that I want you to remember, and this is when you're looking at post-reduction images. Because we deal with so many Colles fractures, what happens is that sometimes when we get the odd Smiths with post-reduction, quite often the cast is applied to the wrong side because the technician is in autopilot and is casting for a Colles fracture because they've forgotten it's a Smiths. So when you look at a post-reduction image, because a Colles fracture is dorsal angulation of the distal fragment, the patient is casted with a back slab on the dorsal side of the patient's wrist, because this will then prevent the fracture from continuing to displace dorsally. So when you look at a post-reduction image, particularly of a Smiths, you want to make sure that the plaster cast has been applied to the volar side of the wrist, because this will ensure that the fracture fragment will not be allowed to continue to migrate volarly. It's the same with the reverse Barton's. The reverse Barton's, the cast must be applied to the anterior or the volar aspect of the wrist because there is volar displacement of the distal fragment. Whereas with our Barton's, this will have a same type of cast as a Colles, so the cast will be applied to the back of the patient's wrist, so that'll be a back stab. So it's always important to really check that for post-reduction images, because if the patient has been incorrectly casted, that can be quite a significant problem, because they won't be brought back to the hospital for another 5 to 7 days, and so that means that that patient's fracture will not be reduced and will worsen, so that has significant consequences. So always look out for what side the cast has been applied and whether it has been applied correctly or incorrectly, because that could save some real problems for the patient in the future. So here is our classics Collis fracture. Remember, Collis fracture tends to occur in individuals over the age of 40. And if we look at this patient, we can see how they've got virtually no cortex. It's really thinned. So these bones are really very osteopenic. And because they're osteopenic, they lack trabecular or bone density. So the lack of trabecular means that they're more likely to sustain this very specific injury, which occurs in the distal radial metaphysis. Now remember, the long tubular portion of long bones or miniature long bones is the diaphysis. In an adult, the flared portion all the way to the end of the bone is the metaphysis. In a child, you have the diaphysis, which is the long tubular portion. Then you have the flared portion, which is the metaphysis. Then you have the growth line, which is the physis, and then you have finally the epiphysis on the top. But remember, once the physis has fused, this entire portion in an adult will become the metaphysis. Okay, so let's have a look. We can quite clearly see there's a real step in the cortex here. And if you look carefully, you can see that the distal end of the proximal portion is here. And we can see that the proximal portion of the distal fragment is here. So there is really quite marked overlap of on the PA view. And then when we look at our head of our ulnar, we can see there is a break in the cortex here and here, and we've got slight angulation of the head of the ulnar. So classically, with a classic Colles fracture, the radial carpal joint is spared. Just want you to have a quick look. This is the scapho trapezium trapezoid joint. We can see how much joint space narrowing there is. Remember, the normal joint space of the carpal joint should be 1 to 2 millimeters. So here we have marked narrowing and sclerosis. This is a real classic location for degenerative changes in people, in elderly people. And now all is revealed on the lateral view. So classically, a Colles fracture is a transverse fracture through the volar or anterior cortex, with comminution and dorsal angulation through the posterior or dorsal cortex. So although this is by correct definition a comminuted fracture because it consists of multiple tiny osseous fragments, we don't actually use the term comminuted in our description or in your how, because when you use the term comminuted, the orthopaedic surgeon is expecting to see very large bits of bone, which they will have to put together in the correct alignment to fix the fracture site to the correct position. And so comminution, which we use for more than 2 fracture fragments, should only be used in that context and not in this context. So let's have a little look at the distal portion of the proximal fragment. And here we have the proximal portion of the distal fragment, and we can see there is actually quite considerable overlap. So that becomes very important to mention that in your how. If we look at the radial articular surface, the radial articular surface should have a normal radial volar tilt angle of 10 to 15 degrees. So what do I mean by the radial volar tilt angle? Well, the radial meaning pertaining to the radius, volar, so the angle should be tilted volarly rather than either neutral, where you have no angulation, or in this case where the radial volar tilt angle has been reversed because of the degree of angulation to the fracture fragment. So this can be quite helpful to use to assess your injury, because if you have a subtle fracture, you may only see a little bit of change in the radial volar tilt angle, which might help you to identify that an underlying abnormality. If we look at this image, we can see that this is our pronator quadratus fat stripe, and we can see that there is bulging towards it, indicating that there is an underlying abnormality causing a bulging to it. And also, if you look at the soft tissue, we can see this really classical dinner fork deformity here. If you look carefully, you can see an area of increased density dorsal to the lunate. So you might think that that might be a fracture fragment, but if we look at it, it's not sharp, it's quite rounded, and it doesn't appear acute. So this most likely is from some previous injury which has happened some time ago and is not relevant to this particular injury. So what is it? It's a Colles fracture. Where is it? The distal radial metaphysis and head of ulnar. How? Dorsal angulation and displacement and overlap of the radius and slight angulation of the ulnar. And here we have a Smith's fracture on the PA view, and we can see how the fracture fragment has considerable overlap. And if we look at the drudge, we can see that the distal ulnar as it's positioned at this portion, and the radius that has been displaced or foreshortened so significantly, it actually projects slightly inferior to the drudge. So therefore there's considerable foreshortening. The drudge should lie at the same level as the radial articular surface. If on a normal wrist view where there is no fracture fragment, if the head of ulnar projects distal to the distal radial articular surface, then we refer to this as positive ulnar variance. If conversely the head of ulnar projects more proximal to the distal radial articular surface, this is referred to as negative ulnar variance. So usually, as I've said, the head of ulnar should lie at the same level as the radial articular surface. So that's something to be aware of when you're looking at a fracture to see whether there's been displacement to the drudge. And as always, our lateral view reveals all. And we can see the distal portion of the proximal fragment, it lies here, and the proximal portion of the distal fragment is here. So we can see that the distal fragment has displaced volarly, and there is angulated volarly in relation to the proximal fragment. So therefore this is your Smith's fracture. Remember I talked about the radial volar tilt angle. This radial volar tilt angle, which normal range is 10 degrees to 15 degrees, this has been preserved because this is a volarly angulated fracture. If you look, we can see the pronator quadratus fat stripe, and there's bulging because of the underlying hemorrhage from that fracture fragment. In fact, there's gross soft tissue swelling because it is really nasty injury. So what is it? It's a Smith's fracture. Where? It's the distal radial metaphysis. How? Volar angulation and displacement. So if we remember, a Barton's fracture is an intra-articular fracture of the radial carpal joint, which is this joint here. So we can see that our fracture fragment has extended up to the scapholunate fossa, so through this location. So a Barton's fracture, because it doesn't contain the letter R with a reverse Barton's, we know that a Barton's fracture is going to be dorsal displacement of the fracture fragment. And if you look carefully, there's a tiny avulsion fracture of the ulnar styloid process. So the key with the Barton's fracture is to identify the intra-articular component, and that's really important because an intra-articular fracture becomes a much more significantly important injury than an extra-articular fracture. So by articular, I mean extending to the joint. So if intra-articular, the joint is affected. If it's extra-articular, the joint is not affected. Now, I don't actually like these images. They're pretty awful, and as you can probably guess, I've ripped them off the internet. And the reason why I don't like this description as a Barton's fracture is because if you remember, the key to a Barton's fracture and the key to a reverse Barton's fracture is that the carpals need to be following the fracture fragment. Now, if we look here, we can see the intra-articular component, but the lunate is normally aligned within the radiocarpal joint, and it absolutely hasn't migrated with the fracture fragment. So technically, I don't think this is a true Barton's fracture, but it's to give you a little bit of understanding of what you might be looking for. So as I said, the key is to identify the fracture through the articular surface, indicating that this is a really quite significant injury. So what is it? It's a Barton's fracture, where it's the distal radial metaphysis and the ulnar styloid process. How? Intra-articular with dorsal displacement. And here we have a reverse Barton's fracture. So if you remember, the head of ulnar should be at the same level as the radial articular surface, and we can see that actually the radial articular surface is slightly proximal to the head of ulnar, and so therefore there is significant overlap of this patient, or of this fracture site on this patient. So that's something to consider, because that will need to be reduced back into the correct position. A significant portion of fractures to the distal radius will involve either the either the ulnar styloid process, which is involved here, that little bit there, or the distal ulnar. So it's important that when you evaluate all your PA views to scrutinise your ulnar styloid process and your distal ulnar very carefully to make sure that there's no additional fracture through there. So on this patient, we can see that there is the intra-articular component, again involving the scapholunate fossa. So this is quite a common location when there is an intra-articular component. So although you should always pay close attention to all aspects of the radial articular surface, you should be aware that the scapholunate fossa is most commonly affected, so that's something to look out for. And the lateral view, as always, the lateral view is so helpful when we're looking at distal radial fractures, because this will identify whether the fracture fragment is moving volarly or dorsally. But here we can see that this really is a true reverse Barton's fracture in comparison to that previous poor example of a Barton's fracture. So a reverse Barton's fracture, because it contains the letter V in it, it means that there is volar displacement. So we can quite clearly see the intra-articular component of the distal radial metaphysis, but most importantly, this is our lunate here, and we can see that the lunate is following the volar portion of the fracture fragment rather than aligning with the dorsal component of the articular surface. So this is a true reverse Barton's fracture because the lunate is following, it's migrating with the fracture fragment, which is important. Now, it can be really difficult to appreciate the ulnar styloid process or the head of ulnar on the lateral view, but we can actually quite clearly see the broken off fracture fragment of the ulnar styloid process. So do try to look at whether you can see the ulnar component on the lateral view. That's quite helpful. And we can see the marked soft tissue swelling and deformity. And here's our pronator quadratus fat pad, and it's not a nice little stripe. There's some blurring to it, indicating there's underlying hemorrhage. So what is it? It's a reverse Barton's fracture, where distal radial metaphysis and ulnar styloid process. How? Intra-articular with volar displacement. The Chauffeurs fracture is a fracture of the radial styloid process. Now the reason why it's called a Chauffeurs fracture, it's after the chauffeurs who used to wind the crankshaft on a car. And if the crankshaft suddenly whipped away from them and snapped back, it would strike the chauffeur across the radial styloid process and causing a fracture through here. Now there's an important thing to note with a Chauffeurs fracture is that what happens is that when clinicians palpate the anatomical snuff box, what happens is the majority of the time people are actually palpating the radial styloid process. So frequently radial styloid process fractures are mistakenly identified as a possible scaphoid fracture, because scaphoid fractures, if there's pain in the anatomical snuff box, there's a high risk of a scaphoid injury. And so therefore, when you are evaluating every single scaphoid image, make sure you scrutinise the radial styloid process to make sure that you haven't missed an undisplaced fracture. Now, in this instance, we can see that there's a lucent line with a break in both cortex. It's an intra-articular fracture. If you look, the alignment is pretty much preserved, so it's only minimally displaced. So we have a minimally displaced fracture through the radial styloid process. So what is it? It's a Chauffeurs fracture. Where? Radial styloid process. How? Intra-articular, minimally displaced. Transverse fractures of the distal radius that are undisplaced can be extremely difficult to see. So it's important that as we go around the cortex of each and every bone, that we look for these tiny steps. And if we look at the lateral border of the distal radial metaphysis, you can see how the cortex has a very small break. And as we come round the other side and down the medial cortex of the distal radial metaphysis, again, this almost invisible step in the cortex. If you look very carefully, you have this faint sclerotic line, and this is your undisplaced fracture. Technically, it's impacted because what's happened is that the bone fragments have crushed together to create that sclerotic line. Remember, when we always check our bones, we go around each and every bone, so make sure that you assess your distal radius, your distal ulnar, look at your carpal bones, look at your metacarpals, just to make sure that there's no further injuries. So what is it? It's a fracture. Where? It's the distal radial metaphysis. How? It's undisplaced. Occasionally, you may get an isolated fracture of the ulnar styloid process. The triangular fibrocartilage complex exists in this space here, and occasionally an injury to it can result in the avulsion of the ulnar styloid process. The rule of thumb, though, is that an ulnar styloid process injury usually occurs with another injury. So if you see an ulnar styloid process fracture, make sure that you check every bone carefully, that you see that you haven't missed another injury. So So what is it? It's a fracture. Where? It's the ulnar styloid process. How? It's undisplaced. We've now reached the end of part 1 and I look forward to talking to you again for part 2.